Here's an Instagram Live with Dr. Alex Weber and I discussing all things shoulder labrum and biceps. We discuss exactly what is the shoulder labrum and its relationship with the biceps long head tendon, common injuries associated with these two anatomical structures and how they happen, how to surgically repair them, and a little bit about the rehabilitation process. Hope you enjoy this one.
The Prehab audio experience will teach you how to take control of your health through knowledge by optimizing performance, promoting longevity, and keeping your movement system in tune. Welcome to your host, the Prehab Guys.
All right, so thanks for everyone that tuned in. If anything, you just heard about a really cool office that Dr. Alex Weber is in right now. So let's just start with introducing him. So Dr. Weber, introduce yourself, and then we'll get started from there.
Cool. So I'm a orthopedic surgeon, sports medicine specialist at USC. As part of my job here, I take care of patients in the community, do a lot of surgery. Take care of the USC athletes, do some research, some stuff hip, shoulder related, some knee. Some of it is in the lab, looking at basic science, rat models of arthritis. Some of it is on patients that we operate on. We see how they do post-operatively compared to preoperatively. And then I take care of the USC athletes with a couple of my partners. So we're over at the undergrad campus at sporting events constantly, just trying to keep our athletes as healthy as possible. In terms of where I came from prior to USC, I did my training at University of Michigan for orthopedic surgery. And then from there, I went to Chicago for a year where I worked at Rush as a sports medicine fellow. At Rush, we took care of the Bulls and the White Sox. And then I came out here, out west. So here I am.
Oh, that's awesome. Actually, Mike is going to be doing an Instagram Live with a couple docs from Rush next week.
Oh, perfect. Who's he going to be working with? Do you know?
I don't want to mispronounce anyone's names incorrectly. Let me see.
Yeah, sports guys.
Yeah, it's crap. I'm sure I could find it while we're going once you get started with something. But
or
what's that?
Is it Cole, Brian Cole, or
maybe him? It's gonna be two guys. We're gonna talk a little bit about like PRP stuff next Monday.
Cool.
I can always pull it up on my phone.
You gotta find it, yeah.
Yeah, for sure. We'll figure it out by the end. And then a little bit about how you and I know one another. So I'm a practicing physical therapist for Aspire Physical Therapy and Sports Performance, located in La Cañada in Glendale. And that's how Dr. Weber and I first met. Dr. Weber refers patients to us there. And then we just sort of built a little relationship, and now here we are today. And we're going to be talking a little bit about the biceps and the labrum. And then sounds like maybe you have one of your patients is someone in here, but it's the Galen crew says hi.
The Galen crew is all of our court sports. So US men's and women's volleyball, and men's and women's basketball and beach volleyball. And that looks like Jenna Adams, who's one of our USC women's volleyball players. Stud and defensive specialist.
Nice. All right, cool. So we're going to get started right into it. Like I said, the title is All Things Shoulder, Labrum, and Biceps. So Dr. Weber, please give us a little intro about this specific anatomy. Break it down for someone that maybe has no idea what this is.
Sure. So the shoulder joint is one of the coolest joints, I think, in our body. It is our most mobile of our major joints, which is really important. So in order to maintain that motion, in such a major joint, we have to really focus on the soft tissue stability of the joint too. So there's always a trade-off. The more mobile a joint is, the more likely it could get injured, because in order to have that motion, you're losing some restraint or constriction of the joint. So there's always this fine balance, and probably the shoulder is the best example of that. We see it frequently in our overhead throwing athletes. overuse injuries, etc., because the shoulder just takes on such a tremendous load while also allowing you to move through space. So the shoulder is a really challenging joint, I think, because of how mobile it is. It's also a great joint to treat because we see basically all spectrums of disorders. So we see young athletes with traumatic injuries. We see clavicle fractures from falls, AC joint separations. We see proximal humerus fractures. And we see rotator cuff tears in the older population. So we really get the whole spectrum of injuries. And today we're going to talk about labrum and biceps. So I'll just jump right into the anatomy a little bit. In terms of the labrum, I have a small model here. So this model is basically looking at a right shoulder. So here's the model for everyone to see. So the shoulder joint is a ball in the socket. So the ball or humeral head is here. The socket is here. All right. This is obviously a nicked up little model. We've used this a lot in the office, which is why it looks like this. But that's the shoulder joint, ball and socket, and all the brown that you see around it. These are some of the ligaments which help keep the ball in the socket. The most important structure to keep the ball in the socket or keep compression of the joint is the labrum. And the labrum is a soft tissue or fibrocartilaginous structure which sits all the way around the socket. So circumferentially around the socket, we have the labrum. And I have an old school model here or picture, which I will show you guys. This is really kicking it old school, but let's see if you guys can see this here. So this picture right here is like a face-on view of the labrum. So you can see that the labrum circumferentially sits around the socket or glenoid, okay? And people
you can even probably bring it closer. I'll tell you what. Yeah. There you go. I think that'll be good for people to be able to see.
Cool. So you can see here, this is a face-on view of the socket. So that's the glenoid. And circumferentially sitting around it is the labrum. So the labrum is a fibrocartilaginous structure. And what it does is help deepen the socket, helps keep the ball on the socket, and also stabilizes the joint or compresses the joint. And one interesting thing is that you hear everyone say ball and socket joint for the shoulder, but probably the best analogy I've ever heard is that it's more like a golf ball on a golf tee. So there's not a lot of restraint to the joint. And the reason it's like that is so that we can have all the motion with overhead activity, with throwing, with playing sports. We need that motion. And in order to get that motion, we sacrifice some of the stability. So I think the golf ball is probably the best analogy. Golf ball on the golf tee, for those who golf out there, is much better analogy than a ball in the socket because it's not really a deep socket. And the labrum is really important for providing some of that stability. Okay.
Yeah, I love the golf ball and the tee analogy because then people understand how big the golf ball is compared to the tee. And that's why there's inherent instability to the joint itself. And then if there's any insult to some of those passive structures that we're going to get into a little bit, the labrum itself, then people really understand, oh boy, so it's like, how do we keep that golf ball on the tee? That's probably the hands down the best analogy there is.
Right. And so just going through some of the basic anatomy here, we talked about, let me grab the other model here. We talked about ball and socket, so humeral head, ball. We talked about socket, glenoid. This prominence of bone comes off of the scapula or shoulder blade. That's called the coracoid. If you push on the front of your shoulder, you can feel the coracoid. And then we have the acromion, which it's also just part of the scapula. So it comes off the shoulder blade and it comes around over top of the shoulder joint. And it connects to the clavicle or collarbone. So oftentimes we hear of quarterbacks, especially getting driven into the ground, landing directly on the shoulder. They often have what's called AC sprains or separations of the acromioclavicular joint, AC joint. So that's the one up on top here, okay? So we have, again, a ball and socket. We have coracoid in the front, prominence of bone from the shoulder blade, which is in my left hand. And then we have collarbone or clavicle coming to the acromioclavicular joint or AC joint right here on top. And this is the orientation, again, for a right shoulder, okay? So that's kind of the basic bony anatomy or osteology of the shoulder. And then we'll talk about labrum, which sits on the circumferentially around the glenoid socket. And then I just want to point out the biceps, which we're also going to talk about. Here we only see the bones, but you can see this small groove that runs in front here. So let me see if you guys can see how there's kind of a groove in the front of the bone there. That's for the biceps tendon as it comes up the arm. Obviously, the biceps sits down lower here, but the biceps tendon comes through this groove and then makes kind of a hard turn as it comes into the joint and attaches up here just on the top of the labrum. So again, I'm going to go back to our crazy old school picture here. So probably the best, tell me when the glare is.
Yeah, even hold it, move it, let me guess, a little bit up, just a tiny bit. Yeah, that's perfect there.
Okay.
And then we'll have comments rolling in if it's not working.
Cool. So this is like the glenoid cavity, and here's the labrum, right, circumferentially around it. And this is, again, that on-face view. So you can see the biceps tendon is this structure right here, which comes into the joint and attaches just on the top or the superior labrum. And we'll get into why that's such an important relationship between the biceps and the labrum, because we definitely need to discuss how labral pathology and the biceps, especially the superior labrum and the biceps, go hand in hand. All right.
Yeah, so I think we can probably jump right into that because sometimes even I have high schoolers come in or observers, and not everyone always understands that intimate relationship between the biceps, long head tendon, and the labrum. So why don't we talk a little bit about that? When someone has a labral issue or a biceps issue, how you explain that to the average person that you see in the clinic or even an athlete, so that they can better understand that relationship. And then more importantly, how it all boils into the shoulder stability.
Yeah. So we see a ton of superior labral tears or slap tears. So superior labrum anterior to posterior are the words that make up SLAP, or the mnemonic SLAP, abbreviation, SLAP, SLAP. So these are tears of the superior labrum at the biceps anchor, or where the biceps anchors into the shoulder. The way I talk to patients about these, typically these are our throwing athletes, our overhead hitting athletes, swinging athletes like volleyball players. And the reason these tears occur, or why that's an intimate relationship between the biceps and the superior labrum, is you can think about it this way, or the analogy I use is it's almost like the biceps tendon, the long head of the biceps tendon, is like a leash on a dog's neck, okay? And so every time you throw or hit a ball in an overhead rapid fashion, there's angular velocity, a lot of force across the biceps and biceps tendon. And as the biceps contracts, the tendon pulls on the labrum. So what that's doing, it's like if your dog starts wandering out of the way and you pull on the leash. Obviously, I don't advocate for people pulling hard on their dog's neck, but what you can imagine is every time you pull, what happens is the labrum feels some of that force or some of that pull from the biceps tendon. And that's what generates the tears in the superior labrum. And I think kind of that leash around a dog's neck is a good analogy for what the forces are like on the superior labrum when the biceps contracts. So what we see is this is not always an acute injury, meaning it's not a one-time event. It's the tennis player who serves over and over again, the throwing athlete who's constantly throwing overhead, the volleyball player who's spiking the ball all the time. These are the athletes who are sustaining these superior labral tears, and it's in part due to the biceps tendon.
Yeah, and I think if anyone out there that's familiar with it, sort of that peel back mechanism. That's what it's commonly referred to, that pulling on it. Also, because you have that shoulder model there, I think it would be great to show the anterior to posterior, right? It's understanding the glenoid fossa itself, imagining it as a clock from the lateral view, because I think that's a really easy way for people to understand that SLAP.
Yeah, so it's up on top here. This is the superior labrum would be sitting up here. Anterior is front of the shoulder, so in this direction. Posterior is back here in this direction. So in this direction, superior labrum, anterior to posterior, this way.
And then building right off of that, so other than the overhead athlete, what have you seen just from practicing that are other ways that people commonly injure their labrum or the biceps?
Yeah, so if we want to focus just on labrum for a second, we really lump labral injuries into a few different categories. So we can talk about anterior instability of the shoulder, posterior instability of the shoulder, and superior labral tears are kind of the big three. So those who injure their anterior labrum are typically doing so by a traumatic injury or dislocation of the shoulder. And that's typically with the arm in abduction and external rotation. So how I have my arm here, and then an anterior directed force on the arm. So a force which then brings the arm forward. And you can imagine in this model, if the arm is out to the side, like this, and then an anterior force kind of pushes the ball off the socket anteriorly. That's called an anterior dislocation. And what happens is as the ball kind of comes forward on the socket this way, it knocks off some of the labrum in the front of the shoulder here. So as the ball kind of pushes forward, it knocks off the soft tissue on the front of the glenoid. And sometimes, and the reason this is all marked up is because sometimes that labrum comes off with some of the bone as well. And we call that a bony Bankart injury. So if it's just labrum, soft tissue, it's called a soft tissue Bankart. If the ball comes off the socket and knocks off some of the front bone here, that's called a bony Bankart. So anterior instability is very common in our contact athletes, our younger contact athletes. That's football, rugby, anything, even basketball related, soccer. Anyone who has the arm in this position and then has a force which pushes the arm forward can sustain a dislocation of the shoulder. So that's anterior instability. That's one group of labral injuries. And that's about, of all of the dislocations of the shoulder, anterior dislocations serve between 95 and 98%. The other form of labral tears are posterior labral tears. And that's when the arm is out in front of you this way. So if you have your arm fully out in front of you, internally rotated, and then there's a posterior force on the arm. And you can imagine that position is somewhat like this. And then that force drives the ball out the back. So from this perspective, you can see the arms here, and then it's the ball is pushed out the back of the socket. This is about 2 to 5% of all dislocations. You can imagine people who are like this frequently are like offensive linemen in football will sustain these injuries. We also see it if a patient unfortunately has a seizure condition, or if they've been electrocuted, we'll see posterior dislocations of the shoulder. And that will knock off or tear the posterior labrum, which is back here, okay? And sometimes also can remove bone as well from either the ball or the socket. And that's a good thing to mention now is in either direction, when, especially with the anterior dislocation, as the ball comes off the socket, you can knock off bone from here. But you can also lodge the ball and socket like this. And the back of the ball gets caught on the front of the socket as the shoulder comes out. And we refer to that lesion in the back, or that dimple in the back of the ball after such an injury, as a Hill-Sachs injury. So we see those frequently as well. So posterior dislocation.
Yeah, I was going to say, what do they refer to as posterior dislocation commonly?
Refer to the posterior dislocation?
Yeah, so like instead of a normal Bankart, or like some questions in like what exactly is a reverse Bankart?
Oh yeah, so if we have, we'll see reverse Hill-Sachs, or bony. So number one, we can have bony injuries off the back of the glenoid. And also if the ball comes posteriorly, we can have what's called a reverse Hill-Sachs lesion, which is when bone comes off the anterior aspect of the ball side or humeral head.
And I was going to say, I think all that's awesome because for a lot of individuals, if they go and get an MRI and they get the results and then they're reading this stuff, these words, they get all confused. People are like, what is going on? I'm trying to understand with my shoulders. Just educating people on these words, I think is awesome.
Yeah, we have all kinds of, unfortunately, we have all kinds of crazy terms in sports medicine and try to name everything. And some are named after former, prolific orthopedic surgeons, and some are named as mnemonics, and some are acronyms. So it's a lot to keep up with. But really, if you just understand the anatomy and you understand the mechanism of the injury, I think it really helps understand how you got into that. Audio.
Someone was not happy that I was wearing a hoodie and a t-shirt. I'm currently home in New Jersey. I'm working from home versus Dr. Weber. He was seeing patients today. So I hope you don't judge me too much. I could have put on a button up, but I would still be wearing shorts under. So that's just me being honest. All right. Awesome.
Is that any better?
Yeah, I think the audio is definitely better now. Okay, cool. So we talked a little bit about that. I think what's a nice transition now is, how do you typically treat and manage these injuries? So whether it's the biceps, whether it's the labrum, whether it's a combination of both, what is your preferred way to manage these? And I know it's a loaded question because it's still going to depend on the individual, but what are some of your preferred methods? Maybe what are some of the procedures that you perform? And then we can just go from there.
Yeah, so, I think it is a loaded question.
Yeah.
I think anytime we see athletes with these injuries, we need to understand a few things. One, what's the athlete's level? Are they in season or out of season? Right? Do they have time now to rehab? Do they need a quick fix now? What they've tried so far. Is this their first time seeing a physician for this, or have they seen someone over and over again? How long they've been dealing with the injury, and then what the injury is. So probably let's start with some of the controversial ones first. If you think about anterior instability of the shoulder, so your typical Bankart shoulder dislocator, the pendulum has swung in both directions over the years. So at first, people were saying, okay, the first time the shoulder comes out, we're going to fix it surgically. Then there's a period of time where we said everyone's entitled to one shoulder dislocation. Once you have your second, then we start talking about surgical interventions. And now for some athletes, we're thinking it may make sense to go back to, if it comes out once and you're a contact athlete, competitive overhead contact athlete, that it may make sense to fix it even after the first dislocation. For the in-season athlete with a shoulder dislocation, we typically reduce the shoulder acutely and then rehab them. So if they can rehab and they have full range of motion and full strength, then we let them back into participation. So I think that's an important thing or a distinction we make with our USC athletes, is full range of motion and full strength of an extremity means you can participate. If you don't have full range of motion and full strength, you can't protect yourself or that joint from a further injury or other joints of your body. So you may be predisposed to having other injuries. And so we always use that motto: full range of motion, full strength equals participation, full participation. So in general, a first-time dislocation, whether it's one of our USC athletes or whether it's someone in our office, we typically try to rehab these patients, get their full range of motion and strength back, and then get them on the field of a player back to competition. Same thing goes for posterior dislocators or even micro instability. So linemen, for example, they don't dislocate the shoulder posteriorly repetitively, but they have what's called micro instability, which means they feel when they're blocking that the shoulder is sliding a little bit, or they have pain in the back of the shoulder. In those athletes, again, we try to do everything we can to strengthen the surrounding musculature and allow them to fully participate. And sometimes in the off season, we talk to those athletes about stabilizing the shoulder. When it comes to the biceps tendon, it gets a little tricky again. We see lots of asymptomatic athletes who will have an MRI scan done for some other reason, and it will show that there's a superior labral tear, sometimes even some fraying of the biceps tendon. We typically try to delineate those that are symptomatic from that versus those that just have that as a asymptomatic finding on their MRI scan. So those that are truly symptomatic from a superior labral tear or some biceps injury, we typically try a conservative or non-surgical treatment for as long as possible. And I know you guys will be talking with the Rush guys about PRP, but sometimes we use some biologic injections in the shoulder.
Yeah, I think the biggest thing, right, it totally depends. Every single person, every single situation is so unique with the labrum, and the pendulum's always swinging. I mean, I remember you and we were at the USC shoulder update,
Yep.
and I believe Dr. Hatch was talking a little bit about it, and there's that rule. Well, okay, there's a really high chance of this happening again. Do we operate now? What do we decide? And I think it's just a case-by-case thing. And more importantly, you talk to certain people, and if it's a baseball player, if it's a pitcher, and they don't have a labral tear, if they don't have some sort of labral pathology, then they're probably not a good baseball player. So I think it all depends on the case. It all depends on the scenario. But say that you do decide to operate on someone. Tell us a little bit about it. What do you typically do?
Sure.
A little bit about just the surgery process.
Sure. So most soft tissue labral tears are fixed with arthroscopic surgery, which means 3 poke holes around the shoulder, definitely smaller than the tip of the finger. Those poke holes are closed with dissolvable sutures, so you don't even have to have sutures removed anymore. The surgery we do, I liken it almost to sewing a shirt button back to a shirt. So what we do is we mobilize or free up the labrum because it typically scars in after it's torn. So we free it up or mobilize it. And then we use small suture anchors and sutures to anchor that labrum back to the bone in its appropriate position. So what we do, for example, here on the model, if the labral tear was in the front of the shoulder here, we would use maybe 1, 2, 3 anchors to repair that labrum back to the bone. We can do that all arthroscopically. It's really a quick procedure, and we can talk a little bit about the rehab as well. Same thing goes for the superior labrum. Typically restore it back to the bone with suture anchors, 2 anchors typically for a superior labral tear. Posterior labral tear, same thing, anchors back to the bone once we've mobilized the labrum. When we talk about the overhead throwing athlete and slap tears, there's also been some changes recently where some patients are having more bicep symptoms, and then we do what's called a biceps tenodesis rather than repairing the superior labrum. Sorry, I lost you for a second.
Froze up a little bit.
Yep. You got me back?
So where I had you left off was biceps tenodesis for individuals, especially throwing athletes, if they're having biceps pain. And I'm glad you brought that up because we get lots of questions about biceps tenodesis, and there's a lot of people that don't really know what it is. So here's a perfect time to explain what is biceps tenodesis.
Yeah. So I think I'll go back to the model here.
Handy model.
Yeah, like I said before, the biceps kind of comes, the biceps tendon, long head, comes up through this groove and then makes kind of a killer turn and comes into the joint this way, and it attaches up here. So what we do is arthroscopically, we can release the biceps from up here where it attaches next to the labrum, and then we can re-anchor it to the bone of the humerus. And we can do that in a couple different ways. We can do it arthroscopically up here, which means we just make another small poke hole and anchor it to the bone here. We can do it through a small incision in the armpit and anchor it down here below the biceps groove. So this is the biceps groove here. Some people will anchor it up here. Some people choose to anchor it down here. And that is somewhat surgeon preference, and also whether you believe that the biceps being in this groove here is a generator of pain or a pain generator. So you can imagine if there's a tendon sitting in a groove, when you're doing things like throwing or moving the arm around, there's some propensity for that biceps tendon to kind of slide around in this groove, meaning it kind of windshield wipers back and forth in the groove or braids on the groove. So people who believe in anchoring it down here say, listen, I want to get this biceps tendon out of this groove or out of a place where it can kind of slide around and cause pain, and anchor it down here, okay? Other people say the groove is not the issue. It's just that it's pulling on the labrum up here. So I'm going to anchor it up here above the groove or in the groove. So that's a surgeon preference. And oftentimes dependent on what how the surgeon's trained, what their experience has been, how their athletes have responded or patients have responded in the past.
What do you like to do?
Yeah, so typically I you'll see when you talk to the rush guys, but I trained with guys who believe that this groove is a significant source of pain. So I make a small incision in the armpit, and then I kind of tunnel under the pec tendon until I can get over here on the arm, and then I anchor it to the bone here. And I saw a number of patients when I was in my training who had either a tenodesis up here, or the biceps was left alone intact and on the bone here. And they said, listen, doc, I still have pain in the front or the anterior aspect of my shoulder. So they point right here. They say, doc, my pain is kind of right through this area of my shoulder. And the minute we take the biceps off of here or release it from where it was tacked down before up here and move it down here, the pain goes away in the front of the shoulder. So I think it's a really, it's somewhat controversial, but sometimes when you take the tendon out or when you do the dissection and you see just how worn and frayed or how inflamed the tendon is, it really will convince you quickly that the groove can be a source of discomfort for patients.
And since I have you on here, I think it's really interesting to talk about the groove. Arthroscopically, maybe in some of those patients that have symptoms, do you see differences in just their anatomical structure of their groove? Is it deeper? Is it more shallow? Is that something that as a surgeon you're considering and you're looking at? Because I think there's actually some questions and some that popped up in this IG Live about it feels like it's slipping. So
yeah,
for some individuals, were they just, unfortunately born and more predisposed to that? Because I've had people ask that. I've had patients ask.
Yeah, so I think definitely there, just like all of us have asymmetries side to side in our anatomy, we also have differences in the morphology of our bones, meaning how our bones develop, and the groove is no different. So some people can have a very deep groove here. So let me see if I can show you. This model has a pretty deep groove here. Some people have a more shallow groove. And that's one thing I really like about doing the tenodesis down here is I've eliminated having to think about what the groove morphology or design is. I just know if I get the biceps down here and out of the groove, then the patient's going to do really well.
Awesome. So now that we talked a little bit about the surgery, about what you're going to do, depending on the injury itself, I think now's a good time to let's transition to a little bit about the rehab. So what's the average rehab look like? Is rehab for one surgery different than another? What should an athlete expect versus maybe the average person? Because there's a lot of people that have these surgeries and they're not overhead athletes either. So I think that's a good transition.
Yeah, so I think for the shoulder dislocator, we can lump them all together. Surgery for the shoulder dislocator and then rehab, typically 2 weeks in a sling, almost full time. Between 2 weeks and 4 weeks, they're starting to mobilize the shoulder. At 6 weeks, they're starting to get their full range of motion back. At 3 months, so 12 weeks, I let them really start going hard with some strengthening, with a goal of between 4.5 and 6 months being cleared for all activities. So typically a 6-month recovery for dislocation, shoulder arthroscopic surgery. The biceps tendon, when we tenodese it, when someone has a tenodesis, we're typically 2 weeks in the sling. After they come out of the sling, shoulder mobility as tolerated right away. So they can get that back in the course of a few weeks if they'd like. And then just no active biceps activities for the first 6 weeks. Again, goal 4.5 months, back to all activities in the gym.
We talked about some of the perks of a biceps tenodesis, especially related to pain, but I think what we haven't talked about is maybe some of the downfalls if you do a biceps tenodesis, especially because that biceps long head inserts on the labrum. And we started the conversation about how there's inherent instability to the joint itself. So when we actually remove that biceps, there's potential loss of some of that dynamic stability. So if you want to touch on that, I think, it'd be cool to hear some of the perks, but also maybe some of the downfalls.
Yeah. So, I think the long head of the biceps can act as a depressor to the glenohumeral joint, or to the ball onto the socket. So when you release it, you are releasing some of the depression forces for the ball onto the socket. Largely when we're doing that surgery, if it's an isolated tenodesis, we're not too concerned about that athlete or individual needing their biceps as a depressing force. In the older patient, sometimes we're doing it with a rotator cuff tear, and we can talk about that in a different segment. But for these patients, some people think the downside is that you're drilling some hole in the bone down here, and you're altering what we call the length tension relationship of the biceps. So the biceps tendon is long. When you tack it down to the bone here, we're removing a lot of the tendon. So it's very important that before we remove that tendon, we make sure that we're maintaining the length tendon relationship of the biceps. So we put it down to the bone here, or anchor it to the bone down here now. We need to make sure that the muscle unit, the tendon and muscle, are still working at their maximal normal length and tension. So if we leave too much there, too much tendon, and it's flopping around, we're not getting the appropriate length tension relationship. So that's an important consideration. The other is if you drill a big hole in the bone here, there are some case reports, meaning there are some instances where people have reported that they put a big hole in the bone here, and maybe they drill it a little bit too close to here or a little too close to here, not kind of center in the bone. And then the athlete goes and does something like throw a ball, and they have a fracture through the bone. So obviously that's a problem, and we want to avoid that. And if you use good technique for this, you can avoid that complication.
Awesome. Yeah. And I think what a lot of people don't know is that, if with the average healthy shoulder, biceps actually helps flex the arm. So actually raise the arm. Yeah. And just because you have that handy model, what does the depression of the shoulder look like for some individuals that don't know what that means?
Yeah. So what that means is, you can imagine the here with the model, here's the groove. So the biceps kind of comes up and into the joint this way. And so what we have is that it pushes the ball down on the socket rather than having the ball sit kind of up on the socket like this. So it keeps the ball centered on the socket because it sits kind of above it this way.
Yeah, and I think we just talked about it, how we could easily do even longer than a 1-hour video on rotator cuff. But someone asked, so Inspire Fitness London, and I'm going to I'm going to paraphrase it a little bit, but
Sure.
is this why you get pain in the bicep area when you have a tear in the supraspinatus? And I think this is a great understanding of maybe what is like referred pain, because a lot of people, especially after rotator cuff surgery, or even shoulder surgery in general, a lot of people really point to pain at the deltoid insertion, but they
Yeah.
always say, hey, my pain's here, or even
Yeah.
after a biceps tenodesis, but I thought the injury was up here. And then people get really concerned because they feel like the pain should be exactly where the procedure was done, where their marks were, but they're getting pain somewhere else. Why is that?
Yeah, so it brings up a good point. So classically, people who have rotator cuff tears have pain over the outside part of the arm here. So they'll come in and they'll say two things to us with a rotator cuff tear. They'll say, Doc, my pain is over the outside part of my arm here, and it wakes me up at night. Those are two classic findings for rotator cuff tears. And that patient has probably a rotator cuff tear until proven otherwise. So lateral aspects of the arm, pain that wakes me up at night, and in the correct patient age, obviously that's not the 20-year-old, that's the 50, 60, 70-year-old. That's a rotator cuff tear until proven otherwise.
Yeah, I love that. And you talked about that in I believe it was over a year ago now, but it's so important with classifying people with what type of injury they're likely to have. And
Sure.
that last point that you brought up, that it's for the older individual. So for anyone that's tuning in, if you're 18 years old and you have pain on the outside of your arm and it's keeping you up at night, and maybe you had a really tough workout, probably don't have a rotator cuff tear. You probably just strained something. So that was great. And keep going. I know I interrupted you.
Yeah. No. And then to specifically answer this individual's question, the rotator cuff and the biceps are very intimately associated in the sense that when the biceps tendon traverses, when it comes through the groove here, the subscapularis tendon of the rotator cuff is right here. So it sits right next to the subscapularis. And then when the biceps comes up on top of the joint, so up here, the supraspinatus tendon is right here. So we think that all of that together is kind of working in unison. So when the biceps starts sliding around in the groove, back and forth this way, that motion can cause tears in the upper border, so the upper part of the subscapularis tendon here. It can also start fraying on the supraspinatus tendon here. And so it is not uncommon that when you lose constraint of the biceps, you start either tearing the subscapularis or the supraspinatus. It's also not uncommon that as the supraspinatus tendon here starts tearing, that it also starts affecting the restraint or the constraint of the biceps tendon. So the two go hand in hand, which is a really good question by this individual, because oftentimes when we're repairing either the supraspinatus or the subscapularis, we're also dealing with the biceps tendon, either with a tenodesis, so anchoring it to the bone here, or sometimes even what's called a tenotomy, which means we cut the tendon and let it retract down the arm.
Another really good question came in. We can start jumping into some of the live questions and some of the questions that people had asked the past 2 days, because there's some really good ones, but we actually covered some of them throughout the intro, so that was good. But athletepro.co asks, what are your favorite special tests when evaluating a shoulder? And I think you can talk a little bit about in general what you like, or then we can even talk a little bit more about what specific tests do you really like for the labrum and the biceps itself.
Sure. So things, just the kind of core or the basic shoulder exam, I think the most important things are first appearance. Do they have any atrophy of the muscles around the rotator cuff? Is there any gross change from one side to the other and how the muscles around the shoulder look, right? Then we want to look at range of motion. So forward elevation, bringing the arm up overhead, external rotation, rotating the arm out to the side, internal rotation. These are the core kind of rotations and motions of the shoulder. And then we talk about strength testing. So we want to evaluate the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. We want to test the deltoid function. We want to test to see if they have pain along their biceps tendon, pain over their acromioclavicular joint or AC joint. So those are kind of the workhorse exam maneuvers that we do. We want to know range of motion. We want to know strength. And we want to know if there are point-specific sources of pain. And then from there, we get into some of the special tests for the shoulder that we use to isolate either certain muscles of the rotator cuff, pain from labral tears or biceps pain, and then what we call apprehension, which means if someone's a shoulder dislocator, we can put them into certain positions that will cause them apprehension, which means they start worrying that the shoulder may come out of place. So for the anterior shoulder dislocator, which is our most common, if we bring the patient into this position where we bring the arm out to the side, as we start to externally rotate the arm, they'll start saying, listen, doc, chill out with that. You're making me nervous. My shoulder's going to come out of place. With the posterior dislocators, we typically lie them down. We'll bring the arm across the front of the body or out in front this way, and then we'll push to see if the ball will slide backwards. So if the ball here kind of slides backwards on the socket, so if they can slide out the back. So those are the main things that we use as kind of the workhorse exam maneuvers. And then sometimes, I don't know if Craig, you want to talk about some of the special tests as well?
Yeah, I think when it comes to the labrum, for the most part, what we learned in school, really how to test the labrum. But for the most part, the patients that I see in the clinic, if it's a labrum issue, more often than not, they've already seen a doc. They've already seen a physician. Yeah. They've already had imaging done, just because a lot of the labral issues that I see is due to traumatic events. Yeah. Something happened. They clearly felt something pop out. They went to the ER, so there was already imaging done. But if I just want to get a better grasp of, okay, well, how stable is this shoulder, and really what provokes their pain, what provokes their symptoms, I really like to look at stuff on the table. So if it's an overhead athlete, okay, I'm going to look at their 90-90 range of motion, that apprehension test that you spoke of. I already have my other hand just on that shoulder to feel it as I'm going through the motion with the other hand holding onto the forearm. I'm looking at some of there's tests called like biceps load 1, biceps load 2. Does that cause symptoms? What do I feel at the shoulder? Those are some of the tests that I really look at. And then, once the overhead athlete, looking at total arc range of motion. So what's their external rotation? So I'll be here. What's their external rotation at this point versus here? If I were to look at it from the side, so if I were over that direction, looking at my head, I want to be able to get this full total arc range of motion. And then basically I go from there. And I think that sort of goes right into, okay, well, based on that, based on some of your examinations, what really dictates what are you going to do? So is there something that you test in the clinic, you already feel pretty confident that you would prefer to operate on this person versus what would you say, okay, let's try PT?
Yeah, I think in general, unless there's a fracture, meaning when they dislocated, they've knocked off a good piece of bone here in the front or in the back if they've had a posterior dislocation, we're typically starting with non-operative care, non-surgical care. And the key things I want to see are, can we get their full range of motion back, and can we improve their strength? And we haven't really talked much about scapular dyskinesia or how someone moves their shoulder blade, but we can talk about that maybe in another section. But we really just want to get their motion back as soon as possible so they don't get stiff, and then increase their strength in a safe way so that we can return them to whatever function they want to do, whether that's everyday life, whether that's hiking and riding a bike, or whether that's competitive sports. So first things first, get the motion back, help them get their motion back. So if that's passively first, and then moving on to active, and then from there, go to strengthening the shoulder and the surrounding muscles.
Yeah, and I think that's the tricky part, especially for the overhead athlete in some of those early phases. That's why it's so important that first session to just find what really provokes their symptoms, because you got to get full range of motion back as soon as possible. Ideally, it's like 95% within the first 6 weeks, I believe. But some of those areas where you have to get that full range of motion for that athlete, that's where the joint is inherently less stable. So what I find in rehab, I know that some of the questions that popped up, well, it's like, okay, well, what's the best to do for rehabbing this? Especially for someone that has they're already apprehensive, they experience a lot of pain, especially if it was a traumatic event. I mean, there's fear associated with getting their arm in a certain position again. So I find with those individuals, getting them to participate in moving their arm, and then more importantly, doing it closed chain. So the difference between closed chain is me moving my arm by itself. This is open chain, versus if I had my hand against the wall, if I had my hand against the ground, move my body on my arm, those individuals, they just tend to do better with that. And you'll see some interesting things. I had an individual a couple weeks ago, no, it was probably like a month ago, strained his shoulder. Couldn't even move his arm on the table. No shot. He was not letting me move his arm passively, but the minute that you could let him help move his arm and provide some feedback to that shoulder, he had the range of motion. But you could easily get tricked by trying to move someone's arm. That's the one tricky thing about a shoulder, is that you have to find ways to let the person help move their arm. Awesome. So I think at this point, for any individuals that are tuned in, continue to ask questions. Dr. Weber and I are definitely going to, we're going to prefer your questions first. But we also had some questions roll in. I think this is a really interesting question, and I would love to hear your standpoint. But what are some of the common mistakes people should avoid after they have a labral repair surgery? What are some of the things that you've seen through your career and your practice that, they come back in, things aren't going as well? Or what have you even had PTs do that you're like, oh, I wish they didn't do that?
Yeah. So I think when it comes to labral repairs, my biggest objective early on is to get motion back, but do so in a kind of safe, systematic way. So I want to see that over the first 6 to 8 weeks, you're gently increasing motion every time that I see that patient back. The patients that worry me are the ones that come back in 2 or 4 weeks and they have full range of motion already. That tells me that maybe I didn't do my job correctly and I didn't tighten the shoulder appropriately, or they've maybe been pushing it a little too much in physical therapy. So what I want to see is like a nice kind of slow stepwise progression of their range of motion over time. And then I tell them, don't worry about the strengthening stuff. When we get to the 12-week mark, that's when I really want them to start strengthening. But really the objective early on is just range of motion. And I think if people kind of have the 12-week mark as a target for full range of motion, and then they go for 3 months or 12 weeks range of motion, 3 months or 12 weeks back to full strength. And I think as long as everyone's on the same page about that, people do very well. Those that have recurrence of labral tears are typically our contact athletes, where the shoulder feels stable. They're just putting themselves in a very high risk position by playing a high risk sport.
Yeah, and expectation, right? Expectations are everything. And then for you and I, we can definitely relate to this. It's happened at least once, but you have to be very careful with what you tell a patient, what they can and cannot do, because they will take what you say and they'll run with it. And then they'll come back in and then they'll tell you what they did. And it's just like, I don't know where you got that from. I didn't say that. And yeah, so I would love to get your opinion on this for the recurrent dislocators, or for someone that had you went in there, you operated on the shoulder, and it was, there's other damage to other structures, the capsule itself. That's a whole nother conversation about winding up the capsule. So from a surgery standpoint, have you ever worked on the capsule itself? And if it was someone that was, maybe it's not even their first surgery, right? Or they had a lot of dislocations, do you expect maybe for that individual not to get full range of motion back? Are you okay if they lack a little bit of range of motion, depending on the sport, of course, right? If it's a volleyball player, we got to get that full ER at 90/90. But I think that's a great question, because it's almost one of those things where, of course, you want to get the full range of motion back, but as you keep adding range of motion, you're inherently adding instability to the joint.
Yeah. That's what we, kind of started the session with about shoulders in general. Is there's this counter or fine balance between, it's the most unstable joint in the body, and therefore we have the most motion in that joint. So in some people, we do have a conversation ahead of time that, it wouldn't be the worst idea in the world if you didn't get crazy external rotation back, right? Or crazy internal rotation back, because those are putting you in a unsafe position, or a risky position to have another dislocation or another labral tear. So definitely there are athletes where we do talk about, tightening the shoulder in such a way that, go ahead.
I didn't want to interrupt you, but did you get the notification too? It says we have like 90 seconds left. So we'll finish with this here, and just to let everyone know, we'll be back on, because the shoulder, you could spend years talking about it. So we'll finish with this question. We have a little over a minute, and then you could always, how can people find you, just in case we run out of time? How can people find you? Where do you work out of? How can they find you on social media?
So my wife will hate me for saying this, but I'm maybe the most available doctor of all time. So
you kind of are. I'm gonna admit that.
On my Instagram page has my personal email address. I give every patient that I see my cell phone number, so I'm pretty much available all the time. Feel free to email me. We can text or call, whatever is best. But obviously, I'm at USC as one of the sports faculty. So I see patients in LA and in Glendale. We have a satellite office, and then down on the USC campus. So I'm pretty much available.
What's your Instagram handle?
So the Instagram handle is Dr. Alex Weber. So just DRALEX. Awesome. I lost you for a second, but DRALEXWEBER. So
perfect. So it looks like Instagram.
I'm always available.
Instagram's going to end our live, but I hope everyone enjoyed it. You can contact either one of us, and then good time.
Yep. Thanks, Craig. I appreciate it.
Thank you for listening to this podcast with Dr. Alex Weber and I. If you enjoyed this, don't forget to rate, review, and subscribe to our podcast. Let us know if there are any other topics you're interested in us covering, as Dr. Alex Weber and I plan to do a separate one on another shoulder topic. If you haven't seen our new website, you gotta check it out. We have some new features, including the body map, which is my favorite, and it makes it very easy to find exactly what you're looking for.